Everyone, welcome back to my channel. Today we will be learning about the chapter Autonomous Nervous System, and today's topic is anticholinergic drugs. We will be learning about atropine in full detail. Kindly watch this entire video for a better and deeper understanding about atropine and anticholinergic drugs. By the end of this video, you would have learned about mechanism of action, pharmacological actions, uses, side effects, contraindications, and classification of anticholinergic drugs. I hope I hope all of you have fun during this video and enjoy this video, and by the end of the video you understand everything about anticholinergic drugs. So without any further ado, let us just begin this video. But before starting anticholinergic drugs, I just want all of you to recall some of the basics that we have already learned or which you already know. So the thing is, so acetylcholine receptors. Let us recall some of the basics. Acetylcholine receptors, we have two types. We have muscarinic receptors and we have nicotinic receptors. In muscarinic receptors, all of them are GPCR. The GPCR in the sense they all are G protein coupled receptors. They are of five types. Okay, M1, M2, M3, M4, and N5. M5. These are all the five muscarinic receptors that are present. Now you need to remember that all the odd numbers, the receptors that have odd numbers, that is M1, M3, and M5, they all are GQ type. That is, they are excitatory in nature. That is, if you stimulate these receptors, they send excitatory signals. Okay, how do they do that? They do that by stimulating phospholipase C, and because of which there is increase in IP3 and DAG. This is just the mechanism of action. If you want, you can remember it, but you have to remember that all the odd numbers, that is M1, M3, and M5, they all are GQ type. That is their excitatory type. When we move further in the video, you will understand that why knowing this is very important, and you don't have to by heart anything only in this entire video or even in this entire chapter. This chapter is very nice because you don't really have to by heart anything. If you know the basics like these, which receptors do what, you can just you can just elaborate it on your own. So moving on, the even numbers, you have M2 and M4. These two are these are GI type, that is, they are inhibitory in nature. And how does this happen? The mechanism of action of this is they inhibit adenyl cyclase, because of which there is decrease in CAMP, because of which there is K plus efflux, and hyperpolarization takes place, because of which inhibitory signals are sent. You just remember that in even numbers, M2 and M4, GI type is of GI type, so therefore it is inhibitory in nature. Okay, so location of muscarinic receptors. First, in the CNS and in brain, or you can see all M1 to M5, all these receptors are present, but predominantly which receptor is present? Predominantly M1 is present. Okay, now outside the brain, in the peripheral organs, you have M1 to M3. See, M1 is present in the stomach. You just remember that what do you love more? You love food more? You love food more, or do you love your love more? So obviously first you need to have food, right? Then only next you can think about other things. So first, food is important. So in M1 receptor is present where? It is present in the stomach. And I told you odd numbers are excitatory in nature. So what does it do? If you stimulate this receptor, what will happen? There will be increase in HCl production. So there's nothing to remember. Now you know why it is increase in HCl production and why it is not decreased, because M1 is excitatory receptor. M2 receptor is present on the heart. M2 is an even number, so it is GI type, so it is inhibitory in nature. So therefore what will happen? It inhibits SA node and it inhibits AV node, because of which there is decrease in heart rate and there is decrease in conduction. M3, it is present in the rest of the body. Where and all can we see M3 receptors? First, it is present in the glands. And now what does it do? You can only tell. M3 is odd number, right? So what it is? It is excitatory in nature. So what does it do? It increases secretions. Glands, what is the function of glands? To secrete substances, right? So it increases secretions like sweat, saliva, and lacrimation. Next is in endothelium. Endothelium, it increases NO production. NO in the sense it is nitric oxide. Nitric oxide, what does it do? It helps in dilation. So vasodilation will take place. Maybe moving on in smooth muscles, since it is excitatory nature, what will happen? There will be contraction taking place. Example is, you can see vasoconstriction, you can see bronchoconstriction, you can see urination. Why can you see urination? Because of urinary bladder contraction. Then you can see intestinal contraction, that is diarrhea. If the intestine contracts more, what will happen? Diarrhea will happen. If the intestinal muscles, they relax, what will happen? The food cannot move forward. So what will happen? Opposite of diarrhea, that is nothing but constipation will happen. Okay, but in this case, what is happening? Intestine contraction is taking place, so diarrhea will happen. So now let us actually start. Those were the things that you had to know before we start with this. I hope all of you understood that. So now let us move into the actual video. That is, the question we have over here is, classify anticholinergic drugs, that is they are also known as muscarinic receptor antagonists, okay, with examples for each group. Describe the mechanism of action, pharmacological actions, uses, adverse effects, contraindications of atropine and atropine substitutes, muscarinic receptor antagonists. So there will be a separate video on atropine substitutes, since it can be asked as a 5 marker. In this video, we will be focusing on this particular question. First, in anticholinergic drugs, you have natural alkaloids, you have semi-synthetic derivatives, and you have synthetic compounds. In natural alkaloids, what do you have? You have atropine and hyoscine. These we obtain directly from plants. So therefore, they are grouped under natural alkaloids, atropine and hyoscine. Hyoscine is also known as scopolamine. Okay. Then we have semi-synthetic derivatives. Under semi-synthetic derivatives, we have the following drugs. That is atropine methonitrate, homatropine, hyoscine butyl bromide, ipratropium bromide, and tiotropium bromide. See, you can remember ipratropium bromide, tiotropium bromide together. Then remember atropine methonitrate and homatropine, hyoscine butyl bromide. HH, you can remember these two first, right? Ipratropium bromide, tiotropium bromide. Then remember HH, that is hyotropine and hyoscine butyl bromide. And the last one was something about atropine methonitrate. You can remember it this way. Now under synthetic compounds, again you have the following classification. You have anti-secretory, antispasmodics. Under that you have quaternary compounds and you have tertiary amines. In quaternary compounds, you can just remember two drugs for each. You don't have to remember everything. In quaternary compounds, you have oxyphenonium and you have glycopyrrolate, you have isopropamide and propanthenine. And then in tertiary amines, you have dicyclomine, you have pyrenzapine, you have valethamate also. In mydriatics, what do you mean by mydriatics? Mydriatics is nothing but dilation of eye. The drugs that help in the dilation of your eye, dilation of the pupil, they are known as mydriatics. You have cyclopentolate and you have tropicamide. And in vesicoselective in the sense they act particularly on the urinary bladder. Those drugs are oxybutynin and flavoxyrate. These all are what? These all are anticholinergic drugs, yeah. Then you have anti-Parkinsonian drugs. You have trihexyphenidyl, you have procyclidine, and you have biperidine. Okay, this is the classification. Moving on, the mechanism of action. Mechanism of action is the anticholinergic drugs. They block the action of acetylcholine. Okay, ACH. They block the action of this neurotransmitter. They also block the muscarinic receptors, all M1, M2, M3, M4, and M5. They can also block nicotinic receptors. This is the mechanism of action. Moving on, pharmacological actions. See, this is very important. If you understand pharmacological actions, no, you can understand the uses very easily. You don't have to remember the uses. If you know this, you can just elaborate it on your own. And then side effects also you'll know very well, as well as contraindications. It's very easy. I want you to pay attention to this pharmacological actions and understand it very nicely. So atropine is a prototype. Atropine is a prototype drug. That is how it is given even in the textbook. So atropine blocks all types of muscarinic receptors. Okay. So first we will be looking into the CNS. Atropine has overall CNS stimulant action. Atropine stimulates. So what and all they're telling? Atropine has an overall CNS stimulant action. So what and all does it stimulate? It stimulates your medullary centers, vagal, respiratory, and vasomotor. vasomotor centers. Okay. But it depresses one thing, and that is vestibular excitation. See, atropine, it depresses vestibular excitation, therefore it has anti-motion sickness. Property. So that is in car or bus, while you're going in a car or bus, what will happen? There is movement of endolymph, because of which the vestibular nerve will get stimulated. This will go to the cerebellum, and this will stimulate the CTZ area in the brain. The CTZ area in the brain is nothing. It is responsible for vomiting, nausea and vomiting. So what will happen? Nausea and vomiting will happen. So this is how it works. In the car or bus, there is movement of endolymph, because of which the vestibular nerve will get stimulated. This signal will go to the cerebellum. This will activate the CTZ area of the brain, and nausea, vomiting will take place. Treatment of motion sickness. Two classes of drugs are used in motion sickness. First one is antimuscarinic drugs, that is the one that we're studying now, and the next is antihistaminic drugs that we will be studying in the next chapter. So the drugs used in motion sickness, first with this will be hyoscine, and in antihistaminic drugs it is diphenhydramine, promethazine, cyclizine, mecalzine, and cinnarizine. These are all used in motion sickness. These are the drugs used in motion sickness. So moving on to the second part, in the CNS only, first we finished about the CTZ area. Now we are moving to the basal ganglia. Okay, in basal ganglia, see, this is what happens in basal ganglia. That is, if this is the relationship between acetylcholine and dopamine, how they both are related to each other. If acetylcholine is more, that means dopamine will be less. Okay, and if acetylcholine is less, then dopamine will be more. This is how they're related to each other. Now, what happens in Parkinson's disease? In Parkinson's disease, there is decrease in dopamine. There's decrease in dopamine levels, right? So that means we can tell that the levels of ACH are increased. So to treat Parkinson's disease, Parkinsonism, we need to increase dopamine levels, right? How do we increase dopamine levels? This can be achieved by decreasing ACH levels. Look at this. If I have to increase dopamine, I need to decrease ACH. So how do I decrease ACH? By giving anticholinergic drugs. This is why anticholinergic drugs are used in basal ganglia, are used in Parkinson's disease. So at higher doses, what will happen? At higher doses, these anticholinergic drugs, they cause cortical excitation, they cause restlessness, they cause disorientation, they cause hallucination and delirium, followed by respiratory depression and coma. So these are, you can tell, some of the side effects or that happens in the CNS. In the CNS, we looked at three parts. First one was that what will happen in the CTZ area. The second we looked at in the basal ganglia, and third we looked at what happens in the CNS if we give it at higher doses. So moving on to CVS, heart. So the brain is connected to the heart with the help of two nervous systems, which we all know, that is parasympathetic nervous system and sympathetic nervous system. In parasympathetic nervous system, the vagus nerve is involved. So the brain sends signals through the parasympathetic nervous system, that is through vagus nerve. This nerve releases acetylcholine neurotransmitter. This acetylcholine neurotransmitter acts on the M2 receptors. Now recall M2 receptors. M2 receptor, it is even number, so it is GI type. So what does it do? It inhibits SA node and it inhibits AV node. So therefore there is decrease in heart rate and there is decrease in conduction. Recall, where were M1 receptors present? M1, what do you need more? You need food or your love? Obviously we need food more. So M1 receptor was present on food, on the stomach, and M2 receptor was present on the heart. Now in the sympathetic nervous system, if sympathetic nervous system gets stimulated, what is going to happen? This will release norepinephrine. This norepinephrine acts on the beta 1 receptor. Why beta 1 receptor? Recall, I have already taught you that where the adrenergic receptors were present. Beta 1 receptor was present at two places, that is heart, as well as it was present on the kidney. Beta 2 receptors were present on pancreas, liver, smooth muscle, skeletal muscle. Beta 3 receptors were present where? They were present in your adipose tissue, right? Adipose tissue and urinary bladder. So therefore you need to know all these very well. So this norepinephrine acts on the beta 1 receptor. See, there's nothing to by heart in this. You should know which receptor is present on heart. You can just write it. So the sympathetic nervous system, it releases norepinephrine. This acts on the beta 1 receptor. And what does beta 1 receptor do? It stimulates the SA node, it stimulates the AV node. Therefore there is increase in heart rate and there is increase in conduction. Obviously, if it is sympathetic nervous system, there has to be increase in heart rate and increase in conduction, right? You can cross verify yourself like this. If it is parasympathetic nervous system, what should happen? Obviously the heart rate and the conduction should decrease, and that is what is happening. Now if I add atropine, what does atropine do? It is an anticholinergic drug. So what does it do? It blocks the effect of acetylcholine, and it blocks the action of acetylcholine, and it causes what? It causes tachycardia. Therefore atropine is used as a drug of choice in bradycardia as well as in AV node block. In all these conditions, for all causes, it is used as a drug of choice in bradycardia and AV node block. Why? Because it causes tachycardia. If there is bradycardia, if I give this drug, then it causes tachycardia and the heart rate will become what? It will become normal and the patient will be saved. That is why we use atropine. But there is a note here, that is atropine is not effective in denervated heart or a transplanted heart. If a transplanted heart is present, it is atropine we cannot give. Why? This is because atropine acts as an antagonist and blocks the action of acetylcholine. But in transplanted heart, there is no vagus nerve. So what is the mechanism of action of atropine? It blocks the effect of acetylcholine, right? But in a transplanted heart, what is happening? There is no another vagus nerve coming here and giving acetylcholine over here. It is just a transplanted heart. So therefore, atropine cannot act in this situation. Thus, if in such a heart bradycardia is present, if we give atropine, no effect will be seen. Therefore, what do we use? We use beta 1. We use beta 1 agonist, that is isoprenaline and norepinephrine. Yes, so we can give beta agonist. You don't have to remember the number. You can just give beta agonist, that is, it can be isoprenaline or it can be norepinephrine. Okay. Now, note, atropine causes initial bradycardia, later it causes tachycardia. Why is this so? See, this is because the initial bradycardia is caused because of block on the M1 receptor on vagus nerve, and this later tachycardia is caused because of block of M2 receptors on the heart. We will look into this now, okay? I know you didn't understand anything over here. So this is the heart, this is the vagus nerve, and here acetylcholine is released. The thing is, we all know that on heart there is M2 receptor is present. But one more thing is, on this vagus nerve, what is present at the terminal end? M1 receptor is present. Now this is a presynaptic receptor. See, this is the synapse, right? This is synapse. So what do I call this? I call this a presynaptic receptor. You need to remember that the function of a presynaptic receptor is to decrease the production of the substance it is releasing. In this case, it is acetylcholine. So this presynaptic receptor, what it does is it decreases the levels of acetylcholine. Okay. Now, when I give atropine, this atropine first it goes and it blocks this M1 receptor. Now, because there is a block in this presynaptic receptor, what is happening? There is increase in acetylcholine. Therefore, bradycardia will take place in the beginning because there is more acetylcholine. This guy will act on your M2 receptor and the normal function takes place, right? Which we saw earlier. M2 receptor will get stimulated and there will be what taking place? Bradycardia taking place. That is, there will be decrease in heart rate, there will be decrease in conduction. Later, what this atropine will do, it will go and block this receptor also. Now it is blocking this M2 receptor itself. So what is happening? Therefore, later what will happen? Tachycardia will happen. First, we learned that it is blocking M2 receptor and tachycardia is taking place. But the hidden thing here was there is another M1 receptor present over here. That is, it is on the vagus nerve, and that is, it is presynaptic receptor. So atropine goes and it blocks this guy also, because of which there is decrease in acetylcholine because of which there is an increase in acetylcholine and bradycardia will take place. Later, this guy goes and blocks M2 receptor also, and then tachycardia is taking place. If you did not understand this, listen to this part again carefully. I'm pretty sure you will get it. It is not that tough. It is very simple. You just listen to it again, or I can repeat it again if you want. First, M1 receptor is there. The function of this M1 receptor is to decrease ACH, right? Next, we have M2 receptor over here. The function of this guy was to cause bradycardia, okay, because he is GI type. Atropine comes and he blocks this M1 receptor, presynaptic receptor. So therefore, what happens? The function is altered. Instead of decrease acetylcholine, the acetylcholine is increased, because of which bradycardia take place. Next, this at initial bradycardia takes place. Next, this atropine after some time goes and blocks this M2 receptor, because of which tachycardia is taking place. You learned this part earlier. Now this another new part you're learning. That's all. Now we will move on with the next organ, that is eyes. So this is your eye, okay? This drawing I have done, this is your eye, this is your pupil, this is the pupil, okay? So these are some of the muscles I have drawn. The red color muscle, this muscle is known as radial muscle, and the another name for radial muscle is dilator pupillae. Why is it dilator pupillae? Because it dilates the pupil. You just you need to imagine over here, okay? This is the muscle. When a muscle contracts, its length, what happens? Its length decreases. So when its length decreases, this pupil size will increase. That is, it'll come over here, something like this, because this length is decreasing, right? And then this blue color muscle that I have drawn, it is nothing but a circular muscle. This circular muscle is also known as sprinter muscle. You just imagine, now if I contract this muscle, this circular muscle, if I contract, the length of the muscle will decrease, so it kind of moves inwards. This muscle move inwards. So what will happen to the pupil? The pupil size also will become smaller. That is, constriction will happen. Constriction is also known as what? Meiosis. So you need to remember this only, basically. The same thing what I told, I have written over here now. I have written that the circular muscle, this blue color muscle, when it contracts, what will happen? It will just move forward like this, because whenever a muscle contracts, its length decreases. Its length decreases and this guy moves forward, and therefore the pupil size also decreases. So what is taking place? Meiosis is taking place. Now, what you have to, the thing is, everybody gets confused which receptor is present where. Right, so for that, to remember it, I am telling it to you in this way. Now, because meiosis is taking place, you recall meiosis, that is constriction of pupil, happens in parasympathetic nervous system or sympathetic nervous system. In sympathetic nervous system, what happens? Dilation of pupil takes place. You have learned this in grade 11 also. And in parasympathetic nervous system, constriction takes place. So if constriction is taking place, that means it is parasympathetic nervous system. So which receptor needs to be present? M3 receptor is present. M3 receptor was present where? On smooth muscles, right? So M3 receptor is present. So you can remember that on circular muscles, which receptor is present? M3 receptor is present. And then on the radial muscle, if radial muscle contracts, what is happening? If the radial muscle contracts, what happens? These muscles will get shorter in length, because of which this pupil will dilate and it becomes bigger. So that is, mydriasis is taking place, and dilation of pupils happen in sympathetic nervous system, right? See, when you look at your crush, what happens? Your sympathetic nervous system gets activated. You keep looking at your crush, so there will be dilation of your pupil taking place. This is how I remember it. So if sympathetic nervous system is present, which receptor will be present? Alpha 1 receptor is present. You need to recall, alpha 1 receptor was present where? It was present on your iris. And where was it present? You need to tell me. Probably urinary bladder. Okay. So this is how you remember which receptor was present on which muscle. So if you just remember this, you can remember it easily. the same thing I am writing below. The same thing I'm writing. See, for the contraction of dilator pupillae. What is dilator pupillae? It is nothing but our radial muscle. For the contraction of dilator pupillae, that is radial muscle, what do I need to give? I need to give alpha 1 agonist. That is for mydriasis. Mydriasis takes place, right? Mydriasis takes place. So I need to give alpha 1 agonist over here. Look at this. Alpha 1 agonist I have to give because alpha 1 receptor is present there. I hope you're getting this. And the same thing if I write it in the name of the other muscle, that is, if this muscle I want to contract so that mydriasis takes place, I want the other muscle to relax. For the relaxation of sphincter pupillae, give antimuscarinic ganglion blocker, that is atropine. That is for relaxation of the circular muscles, so that what will happen, so that dilation takes place. What will I give? I need to block this receptor, M3 receptor. I'll block. So what I'll give atropine. Okay, I hope you understood this. Now I want to cause meiosis. Meiosis is contraction of the eyelid, the pupil. So to cause meiosis, which muscle do I need to stimulate? Think and tell me, which muscle do I need to stimulate for the for meiosis to take place? I need to contract the sphincter pupillae. That is this circular muscle. If I contract the circular muscle, what will happen? Meiosis takes place. So I'll give so therefore I will give muscarinic agonists, okay, or I'll give anticholinesterases. Anticholinesterases are not the same as anticholinergic. Please make a note of it. And then for relaxation of dilator pupillae, I will give alpha 1 antagonists. So overall you need to remember that atropine causes mydriasis. Alright, I hope you understood this. It is very easy. If you did not understand, repeat the video and look and watch it again. Moving on to the smooth muscles. In the smooth muscles, you have the M3 receptor is present. So in smooth muscles, M3 receptor is present. That is, it is GQ type and it helps in excitation. Now if I block this because I'm giving an anticholinergic drug, what will happen? Relaxation will happen. We will look into each of it again, each of the systems now. That is, in GIT, what is happening? The tone and the amplitude for contraction decreases. The passage of chyme, this is chyme, CHYME. The passage of chyme is slowed, so constipation may occur. But the thing over here is, note, peristalsis is incompletely suppressed because it is regulated by enteric plexus. That is, the peristalsis is suppressed, right? Because relaxation is taking place, but it is not completely suppressed. That is constipation. That's why I have written constipation may occur. It's not that constipation will occur. Why? Because most of the GIT muscles, they are regulated by enteric plexus. Next thing is, it causes bronchodilation. There's decrease, that is atropine causes bronchodilation. There will be decrease in airway resistance in COPD as well as in asthma patients. It is helpful in these patients because it decreases the airway resistance. Next, what happens? There is relaxation of ureter as well as urinary bladder. Why is this happening? Can you tell? The same thing. I'm just telling why is this happening, because it is acting on smooth muscles, and on smooth muscles we already knew M3 receptor is present, which used to do excitation, but now because we are blocking it, what is happening? Relaxation of all the smooth muscles is taking place. We looked about it in GIT. We saw therefore bronchodilation is taking place. Now we are looking at relaxation of ureter and urinary bladder. Therefore, what will happen? Urinary retention will happen. Look at this diagram. This is your urinary bladder. Now M3 receptor is not getting activated, so relaxation is happening, no contraction is happening, therefore no urine passes out. Therefore urinary retention is taking place. It is useful to increase the bladder capacity, and it is also useful in neurogenic bladder or in enuresis. Enuresis is nothing but bedwetting that is seen in children. So if I give them this drug, there will be increase in urinary retention. Okay. Next, in the glands, what do glands do? In the glands, which receptor is present? M3 receptor is present. What does it do? Excitation. But now, so therefore there would have been increase in secretions. But because this is not, but because we are giving atropine, this won't happen. Instead, what will happen? There will be decrease in secretions. Therefore, atropine decreases sweat, salivary secretions, tracheobronchial as well as lacrimal secretions. Because of M3 blockade, skin and eyes become dry. In glands, M3 receptor is present, which is GQ type, but we are blocking it. Therefore, what is happening? Inhibition will take place and there is decrease in secretions. That's why I told you don't have to remember anything. If you know some basics, you can just extrapolate it on your own. You can just elaborate it on your own. Next, atropine, it also decreases acid secretion, pepsin secretions, mucin secretions in the stomach, but it is obviously less effective than the H2 blockers, that is histamine blockers, in decrease in acid secretion. That is, if I have to decrease the acid production, I will not be using atropine. Instead of atropine, I use H2 blockers because these are more effective as well as it has lesser side effects. It also decreases intestinal, pancreatic and bile secretions are not significantly reduced. Next, we have to look into the body temperature. There's increase in body temperature at higher doses. Why does this take place? This is because there is a decrease in sweating, right? And there is a stimulation of regulatory center in the hypothalamus. Because of these two reasons, body temperature is increased. In children, this effect is known as atropine fever. It causes hyperthermia. And as a local anesthetic, mild anesthetic action on cornea is seen with the help of atropine. Now, moving on to the uses. If you know the pharmacological actions, you can write the uses on your own. Now, look, it is atropine and anticholinergic drugs. They are used as an anti-secretory, obviously, in where and all in pre-anesthetic medication. When irritant general anesthetic, that is ether is an irritant general anesthetic, okay, was used. Prior administration of anticholinergics such as atropine, hyoscine, glycopyrrolate was used to check increase salivary and tracheobronchial secretion. That is, if I have to give ether to a patient so that irritation does not take place, I need to make sure that all the tracheal secretions and salivary secretions are less. So for that, what we used to give atropine, hyoscine and glycopyrrolate. Next, in peptic ulcers, they are used. Yes, I told you the reason why is explained in the pharmacological action itself. But we use H2 blockers more than atropine. Because why? Because effective doses of atropine causes many side effects. It is also used in pulmonary embolism. These drugs benefit by reducing the pulmonary secretion evoked reflexly by embolism. Next, it is used to check excessive sweating and salivation. Example in Parkinsonism. Yes. The next uses, it is used as an antispasmodics, that is intestinal, renal colic and abdominal cramps. But opioids and NSAIDs are more preferred in these things. And pain relief in renal colic and biliary colic is more due to opioids and NSAIDs than compared to atropine. Any type of diarrhea, that is, it can be drug induced diarrhea, nervous function, drug induced diarrhea, are all controlled to some extent by atropine. Because what does it do? There is relaxation of all these intestinal muscles, so constipation may occur. I had told you, right? So in diarrhea we give atropine because it causes constipation. Spastic constipation, irritable bowel syndrome, modest in these two diseases, it can give some modest symptomatic relief may be afforded. It relieves urinary frequency and urgency enuresis in children. Yes. It is also used in bronchial asthma, asthmatic bronchitis and COPD. Why is it used? Because it causes bronchodilation. Orally administered atropinic drugs are bronchodilators but less effective than adrenergic drugs. Therefore, they are not clinically used. They are bronchodilators but we do not use them clinically. Why? Because adrenergic drugs are more effective than these drugs. Inhaled ipratropium bromide has been found to be effective in asthmatic bronchitis and COPD. Moving on, it is used as a mydriatic as well as cycloplegic. So it is for diagnostic purposes. For that is for testing error of refraction. Now, if a patient comes and in him we need to test if he has any error of refraction, we give these drugs. We give anticholinergics. See, in testing of error of refraction, we need the patient to have both mydriasis as well as cycloplegia. Okay, these both are needed. So the drug that is preferred is homatropine is preferred over tropicamide. Why? Because these do not cause significant these both, this is the drug used, okay, but these both drugs do not cause sufficient cycloplegia in children. More potent drugs like atropine or hyoscine are used. Atropine 1% is preferred in children for in less than 5 years of age. Now, fundoscopy is also a test that is done. In this test, only mydriasis is needed. So we give a shorter acting antimuscarinic drug may be used, but usually which drug is used? Phenylephrine is preferred, especially in elderly. In fundoscopy, we usually give phenylephrine plus tropicamide. The combination of these two drugs is frequently used. Next, therapeutic uses is that atropine. Atropine is used in the treatment of iritis, iridocyclitis, choroiditis, keratitis, as well as corneal ulcers. Atropine, why? Because of long-lasting mydriatic and cycloplegic as well as pain-relieving action. It is used as a therapeutic drug as well. As a cardiac vagolytic, atropine is useful in counteracting sinus bradycardia. Obviously, we already saw that sinus bradycardia and partial heart block in selected patients where increased vagal tone is responsible. Okay, so we give atropine in patients with bradycardia as well as partial heart block in whose in patients where increased vagal tone is responsible. Example, myocardial infarction and digitalis toxicity. In these conditions, what do we give? We give atropine. Okay, the thing is these two will cause this bradycardia as well as partial heart block. That is why we give them atropine. Next, for central action, we already saw in detail how it is used in Parkinsonism, how it is used in motion sickness, and like why it is used in motion sickness. Hyoscine is used. Now, to antagonize muscarinic effects of drugs and poisons. Atropine, that is to antagonize muscarinic effects of drugs and poisons. Atropine is the specific antidote for anticholinesterases. Anticholinesterases example is what? OP poisoning. In OP poisoning, which drug do we use? The drug of choice is atropine. That is what we are telling here. As well as in early mushroom poisoning. Also used for myasthenia gravis, cobra, E-venomation and OP poisoning. Look. Side effects. What can be the side effects of atropine? Atropine causes side effects such as dry mouth. Why dry mouth? You tell me. Because it causes what? Decrease in secretions. If there is too much decrease in secretion, what will happen? There will be dry mouth. This can lead to difficulty in swallowing and talking. There is dry, flushed and hot skin. Fever takes place. Difficulty in micturition. There's decreased bowel sounds. There will be decreased bowel sounds. There will be a dilated pupil, photophobia, blurring of visions, palpitation, excitement, psychotic behavior, ataxia, delirium, dreadful visual hallucination, hypotension, weak rapid pulses, cardiovascular collapse, respiratory depression. In the right, so you can just remember a mnemonic known as dumbbells. This mnemonic is nothing but the action of acetylcholine. The action of acetylcholine causes causes diarrhea, urination, meiosis, bradycardia, salivation. Okay, this and all happens. Lacrimation. Opposite of all of these is this. All of these only you need to write it in the side effects. Moving on to in the contraindications. Atropine is contraindicated in individuals with a narrow iridocorneal angle because this may precipitate acute congestive glaucoma. And we need to be very cautious about using atropine in elderly males with prostate hypertrophy. Why? Because it can lead to urinary retention. So thank you for watching this video. I hope you guys enjoyed this video. If you have any confusions, feel free to comment it down. I will clear any doubts. And if you feel like you didn't understand anything, please replay the video and watch it again. I hope you understood. Thank you for watching this video. Keep studying and keep learning.